In this video, we're going to be discussing pulmonary embolism so that as an RN you understand what it is and how to treat it. Also, stick around until the end. I will be including a bonus question to test your knowledge on this material. So let's get started. Hi guys, it's Nurse Aleen from Go Nursing RN. As mentioned, we're going to be discussing pulmonary embolism. I will be covering the background, clinical manifestations and symptoms, diagnostics, treatment, nursing intervention, and evaluation. First, let's talk about what is a pulmonary embolism. A pulmonary embolism is when a clot or an emboli will be dislodged from our venous circulation into the pulmonary vasculature. It's not going to be in the actual lungs, but it sits in the pulmonary vasculature. To give you a quick background on that, the venous circulation returns deoxygenated blood to the heart to gain oxygen and then perfuse out of the aorta to allow tissue perfusion and oxygen to all of our organs. If a clot or an emboli forms within that venous circulation, it can go through the venous circulation and then get dislodged into the pulmonary vasculature and cause the patients to have shortness of breath, dyspnea, and many other clinical manifestations that can lead to more serious situations as well as possible death. So it's very important as an RN you understand what a PE is and how do we treat it. So the pulmonary circulation, as we all know, to give you a background, is going to start off with that right atrium to the right ventricle. Then it will go into the pulmonary artery. From there, it gets oxygenized in the lungs by going through gas exchange, then out of the pulmonary vein into the left atrium, the left ventricle, and then out of the aorta. The most common type of emboli occurs in our lower legs, which is also known as a deep vein thrombosis, or you will also hear it called a DVT. Now, a DVT is going to be a thrombus that forms either in the femoral or iliac veins that then will travel into the pulmonary vasculature. There are many reasons why DVTs form in the first place, such as poor perfusion, poor circulation. Also, patients may have some blood coagulation issues or cancer that causes the clots or emboli at more risk to form in those large veins and then travel up to the lungs. So it's really important to understand that those that get a DVT have a very, very high amount of chance that they're going to get a pulmonary embolism. So DVT, high risk for PE. So that's a way to remember that. So we always want to assess what kind of patients are most at risk of developing a pulmonary embolism. And those are going to include those that have been immobile for long periods of times. Those that are bedbound or those that are status post-surgery and aren't able to really get up with physical therapy and start walking right away. And the reason for that is that they are at risk of developing the DVT first that then can travel into the pulmonary system. Another set of population is going to be those that possibly have cancer, right? So that's something to keep in mind with coagulation issues. Prolonged travel time or sitting time is going to be another major risk factor. Obesity, right? Trauma, any kind of trauma, oral contraceptives. Genetics is something you want to keep in mind. It can run in families, so that is something you want to be cautious about. And then age. So as we get older, as the organs get older, the vessels, they're going to have, especially the lungs, are going to have decreased elasticity and decreased lung compliance. So if they would to get a PE at an older age, they might have a higher chance of possibly decompensating. Next, we're going to talk about assessment findings and clinical manifestations that we would see in patients that come in with a possible pulmonary embolism. First of all, you're going to see that patients are going to have this very anxious type of behavior, anxious type of feeling because they're going to have shortness of breath and this impending doom. Dyspnea, tachypnea, tachycardic, which then leads them to go possibly hypotensive, diaphoresis, and with more serious pulmonary embolisms or large pulmonary embolisms are going to have altered mental status. So we want to assess their mentation and possible cyanosis. As DVT is a big risk of getting a PE, we also want to assess those calves, right? So we want to make sure, is one larger than the other? We want to possibly take the circumference of the calf to compare. Look for any redness, warmth, and of course pain. They will start to have pain in that extremity if they do have a DVT. In order to diagnose a patient, or what kind of diagnostic test that we do for someone who possibly has a pulmonary embolism, is going to be doing a D-dimer test. That's going to be one of our first laboratory tests that we do. And the D-dimer test is a lab test that's going to measure the fibrin fragments within the blood. So a lot of times when we develop any clots, there's fibrins that get released from these clots, and once they go into our blood circulation, then that's going to be possibly that, hey, there's a clot going on somewhere. But it can also mean a lot of other things, such as an inflammatory process as well. So it's a significant lab value that we use, but it's also not going to definitely tell you that the patient has a pulmonary embolism. So we do want to keep that in mind. Another one's going to be an ABG, arterial blood gas. When we're looking at arterial blood gas, we're trying to see if we have any acidotic or alkalotic changes in our patient. But most important, we're looking at that PaO2 level, which measures the amount of oxygen in the blood. And if the patient has low amount of oxygen in the blood, the patient will be hypoxemic, right? So it's really important that we look at the ABGs as well to see how the patient's PaO2 level. We do a chest x-ray a lot of times to pretty much rule out any other respiratory issues that can possibly be happening, such as pneumonia or an infection. It will allow us to get an image and a visual of the patient's diaphragm and allow us to rule anything else out before assessing if the patient does have a pulmonary embolism. In order to diagnose the patient with a pulmonary embolism, we're going to need to see a little bit more direct imaging that we can get from a CT scan of the chest with contrast. That will allow us to see the blood vessels within the pulmonary system and really evaluate if the patient does have a pulmonary embolism. A CT chest with contrast a lot of times can be contraindicated with certain patients. When we are treating a patient who has a pulmonary embolism and has been diagnosed with a pulmonary embolism, our priority is going to be oxygenation. If a patient has severe dyspnea and shortness of breath and that impending doom, we want to ensure that we place the patient on oxygen and put the patient on a monitor to see the blood pressure, the heart rate, the pulse ox, the respirations, and see if the patient's hemodynamically stable. We also want to continue to assess the patient for any possible bleeding or also if any changes in mentation. So we do want to assess their mental status and see how alert they are, how awake they are, and also how responsive they are to you. Once the patient comes in with a pulmonary embolism, and this goes also for a deep vein thrombosis, a DVT, we want to start the patient on anticoagulation. That is going to be the immediate treatment plan that we do if you're considering medications. There are different types of anticoagulations that you can start your patient on, and most common would be something called Lovenox, or also known as enoxaparin, which is going to be subcutaneous injections that we can give the patients to make sure they're anticoagulated. Our goal is to dissolve that clot, and whenever you're thinking about dissolving a clot, you're going to need some anticoagulations on board. Another type of anticoagulation that is very common is going to be heparin. Right? Heparin is an unfractionized IV drip of heparin, which is a continuous drip that goes through a patient's IV, and we titrate depending on the PTT levels. Now, a lot of times you might see that Lovenox might be an easier route to control the patients because it's easier to control the levels without needing to check the PTT Q6 hours. So that's something to keep in mind. Once the patient gets discharged from the hospital, or as we're getting the patient ready, they will need to be on some kind of oral anticoagulation when they go home, or to bridge them off the heparin drip. Some of those can be such as Eliquis, Perdaxa, and also warfarin. Those are common blood thinners that we can give to allow the patient to be anticoagulated. Now, when we're giving these medications to the patients, it's key to educate them on the risk factors for bleeding. We want them to assess for any bruising, bleeding from the nose, urine, or stool, black tarry stools. Another intervention and medication that can be given would be thrombolytic therapy, also known as giving TPA to a patient that will dissolve the clot and restore that pulmonary perfusion. Now, there are patients that can go to the cardiac cath lab, and what they'll do is they'll put a catheter that actually sits in the pulmonary artery and then will come back to an ICU unit or any pulmonology type of unit, more of a critical care setting, and we will continue perfusing the TPA and heparin through that catheter, and they will continuously have that medication going straight into the pulmonary artery to help dissolve that clot. So let's recap on what are some priority nursing interventions that we would want to keep in mind for a patient that comes in with a pulmonary embolism. First is going to be oxygenation. Administer oxygenation as needed, apply oxygen to make sure the patient's breathing well and ventilating well, elevate the head of the bed, make sure that we keep them as comfortable as possible. These patients a lot of times are going to have a lot of anxiety and that impending doom, so we want to comfort them as much as possible. We want to continuously assess their respiratory status and cardiac status, which includes heart rate, respiratory rate, blood pressure, assess lung sounds and address any new lung sounds that are abnormal, such as wheezes, stridor, and be cautious about that as well. We want to assess that neural status and that mentation as we mentioned previously and provide that support. Also educate the patient on quitting smoking once discharged if they do smoke. We want to consider them to have a more active lifestyle, to make sure that they're not sitting and for prolonged times and moving their legs, right, to increase that blood flow in their venous system to decrease their chance of getting a pulmonary embolism. The key takeaway here is that we want them to move and we want to prevent any kind of DVT as possible. So prevention is going to be key. If we can prevent a DVT from happening, most of the chances we can also prevent a pulmonary embolism. All right, guys, let's test your knowledge on today's material. A 63-year-old male patient that is status post hip replacement started to complain of increased pain in his right calf. The nurse understands the priority nursing care would be to assess the patient. What signs and symptoms might indicate that the patient has developed a DVT? A is the correct answer. Swelling, pain, redness, and warmth. Those are going to be important signs and symptoms to assess if the patient has possibly developed a DVT. If you found this video helpful, please click the like button and subscribe below. Also, share in the comments other nursing topics you would like me to discuss. See you all next time.